Welcome everybody. So, what I wanted to talk about today, put this on for the videographer, is, we've been working now for really a good number of years trying to deal with what you've heard more and more about, which is, most of this is really about prescription opioids. So certainly at Janus we work with illicit opioids, but there's a big crossover. People can get prescription opioids on the street and buy it. I had this one patient that I took care of who was getting 6 Norco tablets a day and then was buying 21 Norco tablets on the street every day because she just needed more than she was getting from her doctor. She didn't talk to her doctor about her concerns and about her worries, and finally she did and got referred to see me in what we're doing in Palo Alto Medical Foundation in what we call our opioid assessment service, where we're assessing patients' opioid prescriptions and how they're working and how they're not working, whether or not what we say opioids have failed or not. And we say opioids have failed. We don't say that the patients have failed. We say opioids have failed because it's what, and in some ways, we have failed too as the healthcare system. So next slide. So, what are opioids? This is the opium poppy that they, grow in various parts of the world, and it's a big import. It actually is the derivative what we get heroin from, but also, what all these substances are. Heroin would be an opioid. Dilaudid is a prescription opioid. Morphine, Norco. One of the things that always amazes me is that of all the Norco, which used to be called Vicodin, now we call it Norco because we reduce the amount of Tylenol that's mixed in with the hydrocodone, which is an opioid. Of all that's made in the world, okay, all that's manufactured, in the United States we use 99% of it, even though we're about 5% of the world's population. So we use a lot of opioids in this country, and we use a lot of opioids in Santa Cruz. If you guys see this one handout that's at the front of the desk, it talks about how the opioid prescription rate per 1,000 residents, we're more than the average in the state of California. We're much more than Monterey County, than Santa Clara County. We're up there more with San Francisco, drug capital of the world, San Francisco from the 1960s. So we use a lot of prescription opioids here, and we also have a big problem with heroin down at by the boardwalk. We just have a lot of opioids in this community. Next slide. I have to say, I do love morphine. I mean, what I do a lot is palliative care, and palliative care is when we take care of people at the end of life. And no one would say we should limit morphine or other opioids to someone who has serious pain who's dying at the end of life. Has a few weeks to a few months left. We have to have this medicine around. But I think what happened was, to be honest, is that pharmaceutical companies said we have not that many people who die every year in the United States, but we have tons and tons of people that have chronic pain, and opioids work for pain. We know that. If anyone's had an operation or thrown out their back, you need some strong painkillers for the short term. Broken a bone, I broke my femur when I was little. I'm glad I had a shot of morphine to help with that pain. But what we don't know is how they affect us over the long term. Next slide. This is me when I graduated in 1989 with my wife. This was about the time I got out of medical school. And next slide. This is what happened with opioids. It was about this decade. So it was about 1980s, 90s, 2000s that we just started to give more and more opioids. So the number of prescriptions dispensed by U.S. pharmacies in this period just skyrocketed. A lot of it was driven by pharmaceutical companies, but also a lot of it was driven, educating us about we should use, more opioids for chronic pain. But a lot of it was driven too by, doctors had maybe 10, 15 minutes with a patient. It's a lot easier to write a prescription and get them on their way. And patients were happy. Pharmaceutical companies were happy. The investors in pharmaceutical companies were happy. Everyone was happy. But then we started to get into problems. Next slide. And we started seeing that even as the rate of opioids went up, okay, that's in the, the top line, and the bottom line is admissions to opioid treatment programs, and then the red line is deaths attributable to opioids. So they all sort of parallel together, and we started to realize that, boy, these medicines, patients seem to want us to keep prescribing them, but they're causing problems. They're causing more and more serious problems. Now, next slide. This was a big slide that really, I think, got people's attention. So these are two lines. One, the blue line on the top, is deaths from motor vehicle accidents. And it got better. Look at that. We were adding airbags. We were adding all these safety features. And the amount of people who died in motor vehicle accidents started to drop. But the amount of people who died from opioid and drug poisonings, overdoses in the United States, started going up. And so 2008, they crisscrossed. And so now more people die, young people, young adults. So they should have had long lives ahead of them. More people die of prescription opioid and opioid overdoses and drug overdoses in general. And I say that because it's not often just the opioids that are doing the problem. Part of the problem is mixing different drugs. So if you have chronic pain, and I see this all the time in my practice, I mean, what happens? If you have chronic pain, you can't work. You go on disability. You feel bad about yourself. You start to get depressed. So then you get antidepressants. You can't sleep very well. So then you get sleeping medicines. Let's say your doctor says, no, I don't want to mix sleeping medicines with opioids, and you're frustrated because you're still having a hard time with life. So what do? You can go and buy a six-pack of beer or drink some. That's legal. Anyone can do that. And so people mix alcohol with sleeping pills, with other medicines that affect the brain. And what we started to see was people overdosing. So most of the time, and this is the case in Santa Cruz, when people die of medication overdose or with opioids in their blood, they often have other medicines in there as well that cause them to stop breathing. Now the sad thing is that when people have, let's say, shown up, and we see this every once in a while, someone shows up at Dominican on prescription medicines, they're not doing anything illegal. They're taking their medicines like they're supposed to. And they get into trouble. And their breathing starts to drop, and maybe they stop breathing, and their loved ones and their family call 911, they ship them to the hospital, and they save their life. They put them on a breathing machine. And everyone in the chart, all the charts, the doctors are saying, look, prescription opioids probably led to this, or prescription medicines are the cause of this respiratory failure. And they call me, and I go to talk to the patient, and I say to the patient, we need to get you off these, or I say to the doctor, you need to get them off these medicines or reduce the dose. And often what I hear is, well, what are we going to do then? How are we going to control their pain? What else would we have to do? And often that's very frustrating for basically patients, doctors. We haven't developed alternative treatments for chronic pain, and so we're depending so much on opioids. Next slide. So here's the challenge, of chronic opioids that we face, and your doctors are facing. So as you go to talk to your doctor, it's important to realize that this is sort of the fix that they're trying to balance. That opioid therapy may benefit some people in chronic pain. How many? What percent? We don't know. Isn't that horrible? We haven't done the studies that looked and showed, okay, this type of patient with this type of pain will do well with chronic opioids. We don't know that. And so your doctors, when you try to talk to them about it, you ask them, doc, can I have some pain meds or whatever for my chronic pain? They're not going to be able to say, oh yeah, we have studies that show us that this works, because we don't have them. Doesn't mean that they don't help some patients, because we all know some people, and all doctors will say, yeah, I have some patients who can stay on a low dose of opioid therapy, maybe a few Norco, 3 or 4 Norco a day. They seem to be doing fine. It allows them to function. They seem to be doing okay. But now we're more and more thinking that that's a small percent of patients with chronic pain. Even though we've started a lot of people on opioid therapy and maybe ramped up their dose. That's what we used to do. You'd come back to your doctor, hey doc, I'm hurting more, and the dose would be increased. We used to think there's really no upper dose limit. And there's really not with opioids. But the problem is, as you go up on the dose, you'll have a little more pain relief for a while, but then you'll get tolerant to that. And then it doesn't work as well. You got to go up again to get the same relief. It's a spiral up and up if it's not working. And as you go up to higher and higher doses, then you start to have more and more adverse side effects, or serious adverse side effects. So we know now that if you get to above maybe, what we call morphine equivalents per day, which is if you try to take, because all these different medicines are named different things. There's Norco, there's Dilaudid, there's fentanyl, there's Percocet, oxycodone, morphine. So if we convert them to what's called a morphine equivalent per day, more or less equivalent dose. If you get above 50 milligrams in a day, 40 to 50 milligrams, we know that the risks start to really go fast up for bad things happening. And if you get above 90, we really think that it goes very high. So the risk of accidental overdose, not on purpose trying to kill yourself, but accidental overdose starts to escalate, really skyrocket. And that's why we start to see, I don't know if you here know about the CDC guidelines. The CDC came out with these guidelines, and a lot of what they based their recommendations on was the fact that we know that as you go up above a certain dose level, your risk of bad things happening really escalates quickly. And so what the CDC said in these guidelines is really what they didn't say you can't go above that dose. What they said was, if you go above this dose, your doctor really needs to be sure that the benefit that you're getting is worth it, because the risks are really high. I mean, we do scary things all the time in medicine. We do bone marrow transplants for people with leukemia, okay? If we don't, they're going to die of their leukemia. So we do bone marrow transplants. So the risks are there with a bone marrow transplant. You could die of the bone marrow transplant. You could die if you get a heart transplant or a liver transplant. But the risks of not doing it are higher. So we have to ask the question, are the benefits more than the risks when we go up to high doses? And sometimes they are, but often they're not. Next slide. So, what we've done in Santa Cruz, we have a coalition called SafeRx Santa Cruz that was funded by California Healthcare Foundation. For the last couple of years, we brought together people to ask these questions. How can we assure that people for whom which opioids are working are doing it safely, minimizing the risk, and then how do we recognize when opiates have failed, and how do we manage that opioid failure? So this is a slide that describes sort of the basic things we should do if opiates are working. If you're on a dose of opiates, or your loved one is on a dose of opiates that is working to control your pain and improve your function, it doesn't do a lot of good if your pain scores are low, your pain is low, but you're asleep all day on the couch, does it? I mean, it might be one thing if you were dying of cancer and only had a few weeks to live for that to be the case. But if you have chronic back pain and your pain is controlled, you think, with the opioids, but you're sleeping all day and you're going to be alive for decades. Is that a quality life? It's probably not. And so you got to take that into account. But let's say your dose is low, your function is great, you're doing well, and you're one of those people that we think can do well on chronic opioid therapy. There's some medical groups in the country that are saying we're not going to prescribe opioids for anyone's chronic pain. And we're trying not to encourage that. We think that there should probably be less prescribing opioids, but for some patients it may work for chronic pain. So what do you need to do if you're one of those that it seems to be working, you seem to be meeting the goals? You need to educate yourself regarding the risks of chronic opioids and know about it. So talk to your doctor. What are the risks about this? And know that driving is probably, you're more risky driving on chronic opioids than if you weren't. We know that now. So you probably shouldn't be driving much. You shouldn't certainly mix it with alcohol or sleeping pills. You need to know that you need to have an opioid agreement with your doctor. I think that's good practice. So if you don't have one and you're on chronic opioids, you should sit down with your doctor and say, look, this seems to be working. I want to have an agreement with you so we don't have any misunderstandings. So let's sit down together. And a good doctor would give you an opioid agreement. We're not saying a contract. It's not a legal thing. This is something just to make sure you understand each other, how to prescribe and how to get the medicines. And then it should lay out in that agreement what the goals are and what you hope to achieve by being on these pain medicines over the long term. Because that's important. How do you know where you're going if you don't lay it out? Okay? And then you need to make sure your medicines are safe and secure. So, I think one of the big things that talk about it has really done a really good job is educate the community the importance of avoiding diversion. So lock up your medicines in a safe container. Make sure it's not just sitting in the medicine cabinet. Because people, and it's happened in this community, young kids have died from meds that have been diverted. They've taken them at parties and they overdose and they die. And it's horrible. And we don't want that to happen anymore. So if you're doing well on your opioids, you need to make sure they're safe and secure, and only you can get to them. And then lastly, this is something that's new that we're starting to recommend more and more, which is there's a medicine called Narcan. And if you were here earlier, Nancy gave a little talk, and she's going to give some more if you're interested in learning about how to use Narcan. And Narcan is a medicine that reverses opioids, the effect of opioids. So if someone accidentally has an overdose, they maybe had a couple beers and they took their painkiller and they took their sleeping pill all at once and they stopped breathing, or they're turning blue and they're stopping breathing, they're not waking up, we have a way to deal with it. And one is to call 911, but if you just call 911, they may not be alive when the 911 gets there. So it's important to have this medicine in the home, just like you would if you had a bee allergy, bee sting allergy. You'd have a EpiPen. Hopefully you never have to use it, but if you do, it's right there. The time to get it isn't when you need it. You've got to get it ahead of time. So ask your doctor for a Narcan prescription. It comes as a nasal spray, also comes as an injectable. Janice gives them out, but now there is a prescription as well that you can get from your doctor. We're working on getting them stocked in pharmacies, so pharmacies will have them. We're sort of hitting challenges with getting insurance companies don't always cover that. It's sort of a frustrating thing, but we're working towards that. So you can have access to Narcan at home if you're on chronic opioid therapy. So if you're, overdosed accidentally, a loved one, family member needs to know how to give it. They spray it up your nose, and you wake up long enough for you to get to the hospital and survive. Okay, so important to get. Ask your doctor about it. Next slide. But most of the time, the majority of the time, we think now that opioids fail. Patients don't fail, opioids do. So, how can I know if opiates have failed me or my loved ones? Next slide. This is what we've come up with in our SafeRx coalition here in Santa Cruz, this definition of opioid failure that I think is very helpful. And what we're going to talk about now is how to translate that. How can you ask the question? And how can you talk about it with your doctor about whether or not opiates have failed? You all have a handout that tries to put it in layman's terms about, what are the issues around opioid failure and how to talk about it with your doctor. Because if opiates have failed you, you need to go back to your doctor and say, look, opiates have failed me for my chronic pain, or they failed my loved one, or maybe someone saying, I think opiates have failed you. I want you to let's talk to your doctor about what we can do about that. We're trying to educate the medical community too about this definition, but sometimes I think it helps for patients to be the ones to say, opiates have failed me. What are you going to do about it? I insist that you do something about it. I want to have this taken care of because I don't want to stay on opiates anymore if they've failed. First question, next slide. Are serious opioid-related effects occurring? These are some of the effects that people get surprised sometimes when we go over them about opioid failure. These things are all side effects of opioids. Some aren't too bad, dry eyes, but respiratory failure is pretty serious. Next slide. So I've highlighted here the ones that really I think we're most worried about and that I see as being the biggest problem. Respiratory failure, when you stop breathing because of opioids, often mixed with other medicines. Second, constipation. Everybody gets constipation on opioids, most everybody. And sometimes that constipation is just horrible. We call it a narcotic bowel syndrome. It's almost like a super irritable bowel that you can't manage, even though you take a lot of laxatives. That's sort of an unmanageable side effect of opioids, that you may need to say opiates have failed me because of this unmanageable side effect. And then down below, see that one that says hyperalgesia. Hyperalgesia is interesting. Hyperalgesia is when opioids cause more pain. Okay? It's sort of paradoxical or ironic that opioids can cause more pain, but we're more and more appreciating that. And the reason for that, the way I understand it is, I explain it is, okay, we all need to feel pain in order to be warned that something's wrong. It's a survival thing that we all have. Now, if we try to block that pain with opioids and fool the body, we can for a while, but then our bodies start to realize, I need to feel pain again, so they start ramping up their sensitivity to pain. And so you end up having more sensitivity to pain than if you weren't on opioids. And this happens pretty commonly. And so it's hard because you say, oh, I hurt more, I need more opioids. When actually what you need to do is get off the opioids, to let your body swing back into balance, your nervous system swing back into balance, and have less pain again. Usually people's pain don't go away, but it goes into a manageable level instead of this heightened escalation of hyper or increased analgesia, pain. The only way to know whether or not you have opioid-induced hyperalgesia, unfortunately, is to come off of opioids. So we'll talk about that in a second. These other things, depression, decreased sleep or sleep apnea, dry eyes, low blood pressure, nausea and vomiting, all these things can happen with opioids. Next slide. So the second question, are opioids being used appropriately by you or your loved one? This is a harder one to really sort of get our hands around. And when we talk with doctors about this definition of opioid failure, we say to them, well, there's some things that clearly are inappropriate and that mean that the patient's opiates have failed. Okay? I don't know if you can see this, but you can read it on your handout. It says acute risk of danger. So if someone is drinking lots of alcohol and taking opioids, that's probably opioid failure because you're really at risk of dying when you do that. And if you can't stop the alcohol, it's not good. Opiates have failed you. We need to stop. Illegal activities. So if you're selling your opioids, that's obviously opiates have failed you, and we're going to stop, okay, right away. Opioid use disorder is sort of the medical term for addiction. When it gets real severe, it becomes addiction. So if someone's lost control over their opioids and they continue to use it despite harm, so let's say the person that gets hospitalized for stopping breathing, and then when we wake them up and save their life and we say, look, we think the opioids did this. We need to get you off the opioids. We'll wean you down slowly. We need to get you off. And if they say, no, I want to stay on my opioids, they've lost control. They want to continue to use something despite clearly defined harm. And that's opioid failure. That's addiction. And then lastly, it's appropriate. There's absence of an appropriate diagnosis. And I'm seeing more and more of this in my clinic where patients come to me and they're on high doses of opioids, and when I look through their records and I try to figure out why are they on opioids, I can't find a reason, really. I mean, they got started on it for maybe they threw out their back, but that was 20 years ago, and their x-rays aren't that bad, and now they hurt somewhere else because they probably have this hyperalgesia, and so they're on high doses of opioids. They hurt. I'm not saying they don't hurt, but we don't really have a clear reason for them to continue on these potent drugs that have a lot of bad side effects and a risk of dying. So those patients probably are inappropriately using opioids and need to be weaned off or switched. And then you got a lot of other things in this category that are not as scary, not in the red zone, but they're in the yellow zone that says, or orange zone. Things like frequently lost or stolen medicines, craving your medicines, early requests for refills. When they go to see the doctor, it's always about opioids and always about pain. Those are patients that we start to worry that, you know, if there are enough of those behaviors, maybe opiates have failed that patient. But again, these are things that you should talk about with your doctor and say, you know, I want to be open, I want to talk about these things. And it may be that opiates have failed me and we need to go down a different path. But this is a harder one, the second one. Often the doctor has to be the one that brings up a lot of these issues. Next slide. And then finally, the third question to ask are, opioids doing what they're supposed to do? And what does that mean? Well, it means that your pain goes down and that your function goes up. I can't tell you how many times I see patients who are on high doses of opioids and yet their pain is still really bad and their function is horrible. That doesn't make sense. You know, and I tell patients, does that make sense? I said, to keep on taking medicine that's not working, that's dangerous, you know, it seems like opiates have failed you. You haven't failed, opiates have failed you. And I would encourage you, if you find that this to be the case, that you're on lots of opioids, or what the doctor feels is a lot of opioids, and it's not working, you should go to your doctor and say, opioids aren't working for me. Let's talk about another path. What other paths are there? I want to get off these medicines, because these medicines certainly can have a lot of risk and cause me to die, and I don't want that to happen. Next slide. Oh, I'm sorry, go back one. We use this scale, you know, and this is sort of what we're trying to teach our doctors at Palo Alto Medical Foundation to ask, is these three questions. You know, that scale of 1 to 10, we know about that. We all know about the 1 to 10 pain scale, 0 being no pain, 10 being the worst pain ever. I've had patients that are on tons of opioids and tell me their pain is 12, 15, even though I tell them you can't go above 10. So obviously opioids haven't worked for them. And going up on the dose may help in the short term, but remember, the higher you go up on the dose, the more risks there are. And so it's unlikely that what happens is you get into this spiraling up of dose without much benefit. Short-term benefit, but not long-term benefit. And I'll often say to patients, do you see yourself on opioids 5 years from now? And they don't want to be. Most patients don't want to be, but they can't see any other path. Now, the second thing that question is, thinking about that pain, how much does that pain interfere with your enjoyment of life? 0, no interference. 10 being completely interferes, you have no enjoyment. And patients sometimes will give me an 8, 9. That's sad, very sad, that someone doesn't get any enjoyment of life because of that pain. And yet they're on doses of medicines that should be working if they're going to work. And then what pain interferes, how much does that pain interfere with your activity is the third question. How much can you do? And if you can't do much, I don't know if the opiates are doing much for you. Next slide. So what can you do? If opiates you think have failed you or failed your loved ones, what are the options? You know, and really, logically, there's only, you can either go up, but no one's going to let you go up, because now we're starting to realize that that's not a valid path. And it's going to help maybe in the short term, but not in the long term. So going up is not going to happen. Stay the same? Well, but they're not working. Why would you keep doing the same thing and hoping that something else changes? It usually is not going to change. So that's not really a good choice. So there's really only 2 options left. Go down, and we call that weaning. And weaning can be hard, obviously. It's scary. It's hard. But if you go gradually, people can do it. The problem I see often is people try to wean too quickly. So patients have been on opioids for 10 years. And that's not uncommon, you know, because remember, we've been doing this now, giving a lot of opiates for chronic pain for a good 10, 20 years. So if you've been on opiates for 10 years, you can't wean off it in a month. You got to take some time, 9, 10, 11, 12 months. Go down about 10% of your daily total dose every maybe month. So it takes 10 months to come off. You just got to go gradually, very slowly off. And sometimes people can do it, but sometimes people can't. And we're going to talk about that in a moment. Functional restoration and exercise. I mean, Bay Area Pain and Wellness is a group we're fortunate to have a clinic in our community that really does a good job of functional restoration. What that means is they work with patients to get their function back. And a big part of what functional restoration programs will do is try to get you off of opioids too. So the wean at the same time that there's a focus on exercise and then behavioral health support. I mean, I'm convinced that a lot of patients take opioids, even though they're not working for their pain, because they help with what I call the pain of life. I mean, patients who come to see me on chronic opioid therapy, not infrequently, I would say commonly, have horrible life traumas. And you know, the opioids may not help their pain, but it numbs them enough that they can get by. And they're survivors. And I tell them that. You know, you're a survivor, but we have a better way for you to survive than to continue to take these medicines to numb you. So instead of going home and drinking a 6-pack, they go home and take their Norco. Or they do both in order to get by and to live their life, to get by their life. Because it's too hard. The pain of life is too hard otherwise. It's interesting, in Utah area, where there's a lot of Mormons, and they can't drink to help with the pain of life, there's more of a problem with prescription opioids. Because that's an acceptable, a prescription from a doctor is acceptable. And so they use that to help them cope with the pain of life. So in order to deal with chronic opioids that have failed, often we need to have access to support. You know, have someone process some of that abuse that someone went through. It's not uncommon when I see patients to tell me I ask them about abuse and they've never told anybody. And when I ask, have you ever processed that? Have you ever talked with anyone and gotten through it? And I'm not a therapist. So I don't know how to work with someone for like post-traumatic stress disorder or childhood abuse. I don't know how to necessarily do it other than say, let's get you hooked up with somebody. But it's hard. I mean, there's a lot of stigma with being addicted. You know, that carries a lot of stigma. People don't want to admit that. And there's a lot of stigma to go through processing very painful traumas in your life too and seeing a therapist. So there's a lot of stigmas that prevent people sometimes from seeking the help they need. But we need to certainly make sure they have access. And then complementary therapies, I mean, sometimes people get lots of help from acupuncture, chiropractic, massage. I mean, unfortunately, there's barriers insurance-wise and don't always pay for it, but I think we're fortunate in this community that we have some good practitioners in all those modalities. And then what happens if you can't wean? If you say, I just can't, or I've tried to wean some and I've got down a little bit, but I can't get further. One of the things that we're starting to do more now is use a medicine called buprenorphine. Next slide. And buprenorphine is what's called a partial opioid agonist. It's used for people, yes, that have struggling with a heroin addiction. So it's called Suboxone when we use it, or Subutex when we use it for that purpose. But buprenorphine is a good painkiller, and it's used by anesthesiologists to relieve pain. It's also it's available as a patch or as a sublingual film indicated for pain. Same medicine is also used as a tablet under the tongue or a film under the tongue to help people manage opioid addiction or opioid use disorder. And we're using it more and more in patients for whom which opioids have failed. And you could say, Dr. Morris, how can you use this medicine in patients who aren't clearly addicted? And I say, well, if you look at the diagnosis, how do you make the diagnosis of opioid use disorder or addiction? And the new criteria, the new guidelines talk about two criteria. The first two, there are a number, like 12 different criteria. But the first two is someone been using opioids at a higher dose and for longer than anticipated. And the second criteria is they're trying to cut down and they can't. It's too hard. And if you meet those two criteria, and I would say most people for whom which opioids have failed meet those two criteria, they have a mild opioid use disorder and should be eligible by any insurance company standards to get this access to buprenorphine. And one of the few good things about opioid crisis that we had now in this country is that insurance companies are open and willing to provide these medicines for their patients because they realize that it's needed to prevent death. It might be safer. We think that it's hard to overdose on buprenorphine. It's not that hard to overdose on methadone, another drug we use for opioid addiction. But for buprenorphine, it's hard to overdose. Stop your breathing. Unless you mix it in with a lot of alcohol and a lot of sleeping pills. But it's harder. So it's safer, okay? It prevents withdrawal because it sits in the receptor and prevents people from feeling withdrawal symptoms if they go off of opioids. People that are on buprenorphine, my experience is that they're less depressed and they're more alert. Their brains work better. They're not as sedated. Now, that might not be a good thing if you're taking opioids for the pain of life. And I tell patients that. I go, you might find that you will be more awake and alert. But I say, if we're ever going to get past the trauma, if you're ever going to get past the trauma that you've suffered and maybe are using these medicines to help you cope with, you're going to have to be able to be engaged with the therapist and work on this. And so buprenorphine allows them to do that more. And maybe it's less constipating. Not everyone tells me that, but a lot do. Next slide. It comes under different names: Butrans, Bulbeca, Suboxone, Subutex, Subzol. One of the barriers that we have in any community is that you have to have 8 hours of special training. And here's the irony. As a doctor, I can prescribe as much painkiller to as many patients as I want. But in order to use a medicine that's safer to help people get off of these medicines when they're failing, I have to have 8 hours of special training. That's an irony if there ever was one. But more and more we're trying to work towards getting more and more doctors that can prescribe buprenorphine in our community. Now, if you're getting buprenorphine for pain, you don't have to have that training. You only have to have the training if you're using it for opioid use disorder. It almost always requires an authorization from your insurance company, but it's not that hard to get. And often patients will say, don't you have to go through opioid withdrawal first? Don't you have to go into withdrawal before you can start the Suboxone? And that often is the case, but more and more we're getting experience with using different techniques to avoid that step. And we can get people straight from an opioid to Suboxone without as much withdrawal in between. I would say if this is something that's interesting to you, talk with your doctor and say, hey, opioids look like they're failing me. Let's go over, maybe opioids have failed me. And I've heard about this medicine, Suboxone. Can you prescribe it? Or say to the doctor, can you refer me to someone who can? And I think we're getting more and more, like I said, providers in our community that can prescribe it. And the goal would be that everyone has access that needs it. Next slide. All right, I call my last slide healthcare apology, and I've talked about this already, but I do wanted to finish this up to say that, you know, if you're someone here today, or you know someone who, for whom which opioids clearly seem to have failed, I want to say I'm sorry for the healthcare system, because the healthcare system has done this to, in some ways, our country. I think there's other people to blame, insurance companies, pharmaceutical companies, but patients aren't the ones to blame. I mean, I think there's the sense that, oh my gosh, we've made all these addicts. What we've done is we've given people medicine that, I mean, in defense of the doctors, they were trying to help. They were trying to make his life better with less pain. But we've ended up doing something that we need to say we're sorry for, and let's work towards giving people that have chronic pain a better life. I tell people, you're not, I mean, often this story that people tell themselves when they have chronic pain is that I'm a loser, I can't work, I have bad relationships, you know. But I tell people, no, you're not, you're a survivor. You know, you've survived, you're not dead, you haven't overdosed yet, we don't want you to. So you deserve better, you deserve a life with less pain, less sedation, less side effects, less stigma attached. People, when we do shared medical appointments in PAMF about the risks of opioid therapy, and we're trying to get all our PAMF patients to go to one of these educational groups, and we start out the group and we say, who here feels judged by the opioids? And everyone raises their hand. They have a hard time with the pharmacist, they have a hard time with their doctors, when they go to other doctors. So I say, I'm sorry for that, and we need to change that. We need to say, look, if opioids have failed, let's get you off them. Let's find a different path. There is going to be a subset of people that really clearly have, really are embedded in addiction, and they're going to be harder to take care of. But we're going to have to, I think there's a huge population of patients that if we offer a different path for managing their pain that doesn't use opiates, they will take us up on it gladly. It's just we haven't done that yet, and now we're starting to try to do that. So go back, talk to your doctors, and say, I want a different path. I don't want to be on opiates anymore if they're not working. Thank you. Do we have time for questions?
Dr. Morris, thank you very much. You helped my mother when she was a driftwood at the end of her life, so I appreciate that greatly. My question is this. Are doctors doing a mental health and suicide risk assessment before they prescribe an opioid?
I don't think every doctor does, but I think we're starting to realize the importance of doing mental health screening, as you said, before we prescribe opioids. Now, sometimes we don't have the time. If someone breaks their leg, we're going to give them a shot of morphine. We're not going to ask them. But if it's for chronic pain, I think we're starting to realize, yes, there's certain things that make people at higher risk for bad outcomes. If they have a history of abuse, have a history of mental health problems, if they have a family history of problems controlling substances, whether it's alcohol or drugs, you have a much higher risk if you get exposed to alcohol or drugs to also getting into trouble. So we're trying to teach our physicians to do that screening so that we can be more aware of the risks.
May I comment? I know opioid overdose is a problem, and I see that in Santa Cruz County in 2016 there were 34. May I comment though and say that Santa Cruz County has consistently for over a dozen years had one of the highest suicide rates nationally and statewide, much higher than those averages. 52 suicides in 2016. 32 out of the 52 happened to involve either illegal drug, a prescription drug, or alcohol. I feel as though here in Santa Cruz County, we are failing our population when it comes to assessing, managing, and treating suicide risk.
It's interesting that you say that. There's been people that have said that, one of the reasons why we have this opioid prescription and illicit opioid crisis is all the challenges we faced over the last 10, 15 years with the economic downturn and a lot of stresses in general life. And people are, again, turning, with the pain of life going up, they're turning towards medicines to help them manage that. And it would fit that we have lots of opioid use in Santa Cruz and we have lots of suicide.
Maybe one more question. We don't have a lot of time. We've got another great speaker coming up here.
And I'd certainly be around if you want to talk to me.
We got one
Yeah.
more question. One more.
Is the science behind this finding that there's something about this class of drugs that makes people's brain chemistries just, I mean, people who were never addicts are suddenly very addicted after taking, opioids. Are we finding that?
Yes, I mean, and I think that Nora Folkall, who's the head of the NIDA, National Institutes of Drug Abuse, in the U.S., is starting to get at more and more in her research and the researchers about how we really change our brains when we put people on these medicines. It does seem like there is a genetic component as well, so some people are resistant to it. When my wife gets Norco, she hates it. And so you're protected if you hate it. But some people get Norco and they go, wow, that was really good. And I like that. And so those people we got to worry about. So there's a difference, but I do think you're right. It does affect your brain in physical ways. I think if anyone's interested, that the Surgeon General came out with a wonderful report a good, well-written report on addiction in America, and really outlined how, we need to really deal with this as a disease, and that's more and more the message. It's not a moral failing. It's interesting, there's a great article about Portugal apparently has made it so it's not illegal anymore, and someone gets arrested for gets incarcerated for using drugs, they're put on treatment, and they've seen an amazing drop in their problems in the country. But it's very complicated, hard to go over in a few minutes.